Welcome back for part 2 of ALH 4, chapter 13 lecture. Let's talk about diagnostic procedures. So, an ophthalmoscope projects light to view the interior parts of the eye and the retina, and the eyelids are examined for edema and swelling. Pupils are examined for shape, symmetry, reactivity to light, and movement coordination. A slit lamp, which is a biomicroscope to view details of the eye, requires mydriatic eye drops, and the mydriatic eye drops are an agent that induces dilation of the pupil. An exophthalmometer measures how far the eye protrudes beyond the edge of the socket. So you should know this from our abbreviations earlier this semester. What is PERLA? PERLA stands for pupils equal, round, reactive to light, and accommodation. It is charted by the physician if the pupils are reacting normally. Distance visual acuity. The best single test for vision screening is the Snellen chart, and it's the alphabetical Snellen chart. Patients must be able to view the chart at eye level from a distance, and the chart should be illuminated with maximum light. So it's important when you're selecting a place in the office, which when you go in, it will probably already be selected for you. But when they selected the area in which to put the Snellen chart, it's important to make sure that there's the maximum lighting in the area. I have seen this in a doctor's office where it was pretty dark and it did make it more difficult to see. Because this is a gross screening of visual acuity, patients are usually allowed to use their glasses or contacts, and you saw that in the resource videos. We are going to ask them if they typically wear glasses or contacts, and if they do, we like them to have the contacts in or put the glasses back on in order to complete. Document the use of these corrective lenses on the chart, because it's important to know what their acuity was. If they were wearing glasses or contacts, we need to know that. In your documentation, you need to include if there was a use of corrective lenses, the results of each eye separately and as a fraction, and the outcomes of each test with appropriate abbreviations. So how do we record these tests? The numeration, the top number, is the distance of the patient from the chart, which is 20 feet. And the denominator, the bottom number, is the lowest line read satisfactory by the patient. For example, if the patient reads the 20 line at 20 feet, your fraction would be 20/20, and this is what's recorded for that specific eye. The last line the patient can read without squinting or straining, or with no more than 2 mistakes, is the line that's recorded in the patient's chart. Here are some different samples of distance visual acuity. So again, I worked in pediatrics, so this is the first chart. When we started, we would start with little ones, and we would use this chart because typically they know a heart. And we'd ask the child, what is this called? What is this called? So that we knew what their term for this is. For example, here, one child might call this a cross, and another child might call it a plus sign. So it's important before you start a distance visual acuity test with a young child that you understand that you're using the same terminology. Here is the screen where we talk about, in this Snellen chart, showing which way the E is pointing, and they can use their hands to demonstrate which way they're seeing. And then again, what we've been discussing in the last slide is this Snellen chart where they're reading to the best with no more than 2 mistakes. Remember that. If they have 2 mistakes, you go back up to the line above it. You can find this in figure 13.9, and I want you to take a look at that, especially when you're working on procedure 13.1, because 13-1 outlines the procedure for measuring distance visual acuity with the Snellen chart. The near visual acuity is usually, this test is frequently given to patients initially to screen for presbyopia or hyperopia, and the patient reads the card starting at the top until reaching the smallest print that can be read. The patient holds the card with varying sizes font from 14 to 16 inches from the face. Test each eye while the other eye is covered but open. So when the other eye is covered, you don't have them close it and cover it. You keep that eye open but cover it. And then you document the number at which the patient stopped reading for each eye, whether corrective lenses were worn, and any signs of eye strain. For example, if you noted that while they were doing the whole thing, they were squinting, that is a sign of eye strain, so you would want to document that. Again, you can find this on figure 1311 that shows the chart for the near vision acuity test. Take a look at that in your book. These are a color vision test. This tests for defects in color vision and the congenital or acquired. So it can be a congenital effect or you can acquire color blindness. And it assesses the perception of primary colors and shades of colors. The polychromatic plates with numbers of one color and the background dots are different colors. So again, you can see this in your book. If the score is 10 or higher, the patient is within the average range. If the score is 7 or lower, the patient is suspected of having a color deficiency, and the ophthalmologist performs additional assessment tests using more precise color vision testing equipment. And here you can see how the background is a different color, and then here, well, and maybe some of you can't see what that says. If you do struggle with color blindness, you might not be able to see that. But procedure 13.2 in your book provides the protocol for assessing color acuity using this test. Treatment procedures. So eye irrigation, which we're going to be doing this procedure this week, you use sterile technique and equipment to avoid contamination. This is used to relieve inflammation, to remove drainage, dilute chemicals if chemicals have been splashed or spilled into the eye, or to wash away any foreign bodies. You never want to attempt to remove foreign bodies with an applicator. This can damage the eye, and you can actually scratch the lens or any part of the eye. Installation of medication is to treat infection or to soothe irritation. We also can anesthetize the eye or dilate the pupils with installation. And the eye drops or ointments are common in order to do this. And we want to make sure that we use aseptic procedures in ophthalmology because we want to avoid contamination of eye medication applicators. So we don't want to place the applicators into the eye, then the eye is contaminated. Now we use it on another patient and we've now infected that other patient. Sterility of medications is critical. Again, we're putting this into the eye, so you can see why that would be critical. The eye is irrigated, again, to relieve inflammation, to remove drainage, to dilute chemicals, or to wash away foreign bodies. And newly opened sterile solution should be used for each patient and should be discarded after installation or given to the patient for home use. Again, we don't want to cross-contaminate these. Procedure 13.3 details how to perform the eye irrigation, and 13.4 how to instill the eye medication. You are doing cue cards on both of these, and you will be practicing these procedures in class. So please take a look here. You can find this in your book again. It's talking about safety precautions. We never attempt to remove a foreign body. So you can tell that I'm telling you this again. So I really want you to remember, okay? From the cornea, using a cotton tip applicator, this scratches the cornea and may result in causing scar formation and impaired vision. Also, whatever the medication, the dispenser should never touch the eye while the prescribed amount of medication is administered, this can traumatize the eye and can contaminate the medication applicator. If the tip of the dispenser touches any surface, you need to dispose of it in a biohazard waste container. It is contaminated. And we talked about this, we've talked about this with several things, real life versus what the protocol is for your office. In our office, if it had touched the tip, because it wasn't dripping with bodily fluids and we could put the lid on so it was contained, we could place this in the regular trash. But again, in the book, it always says everything goes into the biohazards. We've discussed why sometimes they don't, because of the high cost of disposing, and the risk isn't there with some things, or at least the providers that you work for. They still can follow the strict rules and protection, but if it's not dripping and it is contained, then it can go into a regular trash if that is the protocol in your office. Now let's move on to the ear. The outer or external part of the ear has the auricle that leads to the auditory canal, and the auricle collects sound waves and sends them down the auditory canal. Then you have the middle ear, which is the tympanic cavity, and then the inner ear called the labyrinth. And this is where you'll find the organ of Corti, which contains the receptors for sound, and that is located within the cochlea. And here you can see all the different parts all the way through. So, sorry, went the wrong way. Sound coming in. And here's the semicircular canals. This is a smaller piece. You can see this in your book as figure 1313 if you want to look more closely at that. Now we'll talk about some disorders and hearing loss. So conductive hearing loss is caused by a problem that originates in the external or middle ear, and the sensorial neural hearing loss results from the abnormality of the organ of the corti or the auditory nerve. So this figure as well, you can see 13.4, and this shows the different causes of the deafness. Here the conduction deafness, and here the nerve deafness. And you can look more closely at that in your book. Otitis externa, it's also known as swimmer ear. The causes are dermatologic conditions, trauma, continuous use of earplugs, earphones, and also swimming. And this can be pretty common. I know I myself, actually my whole family has had swimmer's ear. Have you ever had swimmer's ear? So with otitis media, there's serous otitis media and suppurative otitis media. Serous has to do with pressure, suppurative has to do with fluid. It's often associated with upper respiratory tract infections or allergic reactions, and otitis media is most common in children. So again, what's the difference between otitis externa and otitis media? Otitis externa affects the external ear canal and is called swimmer's ear. Otitis media is an inflammation of the normally air-filled middle ear that results in a collection of fluid behind the tympanic membrane. A tympanogram may be done to determine the air pressure of the middle ear and the mobility of the tympanic membrane. Impacted cerumen, so this is often seen in pediatrics, general practice. This is when we would be doing an ear lavage or an ear irrigation. Cerumen is a soft yellowish waxy substance that lubricates the external auditory canal, and excessive secretion can cause hearing loss, tinnitus, feeling of fullness, and otalgia. Impacted cerumen can cause conductive hearing loss because it is actually blocking the sound and the sound waves. How is impacted cerumen removed? Well, we just talked about that. It can be done by softening the wax with oily drops, such as carbamide peroxide, and then irrigating the ear with warm water until the plug is removed. And so ear irrigation or ear lavage can be done with or without that drop to soften the wax. Figure 13.9 shows instruments used in otoscopic testing, and a number of tests are used to assess the hearing acuity. And how many of these things can you name? In fact, why don't you send me a text or an email? Well, a text through Remind, of course, or an email, and let me know how many of those you can name